Okay, so listen, my name is Michael Wren. I'm a founding member of CLL Ireland because my wife Jan, who you heard speak earlier on, patient since 2011. So we realised at that time that we were going to have to get into patient advocacy to make sure that we get the treatments available in the south of Ireland. And we work with great international community as well. So I'm delighted actually to take this panel because I like panel discussions that can go in different directions. What I'm going to do is that you've already met our first two speakers, Laura and Sarah. And what I'm going to do is I'm going to introduce Ben Kennedy and maybe give him a mic and let him do his own introduction, you know.
My name is Ben Kennedy. I'm a clinical haematologist, and I've been looking after people with CLL for a very long time. I had a great pleasure to work with a number of people who you may be familiar with some of those names, people like Terry Hamlin, when I started working in CLL clinics in Bournemouth a long time ago, sort of 35 years ago. And I moved around. I did some registrar training in Cork, so I'm back home again, which is great. And I worked in Leicester for 25 years, and I ran clinical trials there, primarily in CLL, but a lot of lymphoma trials as well, mantle cell and follicular, but very much a focus on CLL. And I think that was because of those early influences from some of the people that I'd had really the privilege to work with. People like Terry in Bournemouth and Pete Hillman in Leeds. I was in Leeds as a senior registrar for 6 years and a research fellow at the University in Leeds, where I looked at some of the immune complications of monoclonal antibody therapies like Campath, which is, it's not something we use anymore. We've moved forward a lot since then, and it's been such a privilege to work with people who've got CLL over such a long period of time. And I've got many friends in the patient group in Leicester who I miss greatly. And I hope they're well. And if any of them are listening, hello. And I hope all is well with you. And I'm looking forward to making more connections across Ireland. I've been one of the principal investigators for the FLAIR study in the UK, and principal investigator on, 30, 40, 50 studies over the years. So it's with a bit of background and interest that I have that I would be very happy to share. I'm not sure that it's different from being an expert. I don't know what an expert is. I've worked with CLL support for many years. I've had a long-standing interest in doctor-patient communication. I used to run workshops with Steve Johnson for the European School of Haematology. Brian will be very well aware of that. And that was a fantastic experience. So anyway, there you go. That's enough about me.
Brian.
Hi, everybody. It's a pleasure to be here. I enrolled as a trustee of CLL support in 2017, I think it was, and I did my 2 3-year terms. We're allowed 2 3-year terms, and then we have to step down. So I'm now an associate. I'm here, I guess, as a patient supporter or carer, and that's if I have an expertise, I guess that's what it is. When my wife was diagnosed, many years ago now, Terry Hamlin was still, the great Terry Hamlin was still around, and we contacted him, and he was the most likable, affable chap you could ever meet. And we said, we got CLL, what do we do? He said, find out Ben Kennedy.
Hi, I'm Ropinder. I'm Chief Executive at Lymphoma Action, so one of the charities that was mentioned. We predominantly provide information and support for lymphoma, and we include in that CLL because of the close proximity to SLL. And because a lot of our medical advisory panel and clinicians also think we should cover that area, and we have worked closely with CLL support in the past. We also do provide healthcare education, so it's lovely that some of the healthcare professionals here have, including I think Laura, you've attended one of our events as well. So yeah, so that's a little bit about the charity. I myself have been in the healthcare charity sector for quite a while. So I've worked at different disease-specific charities. And in the past, I was a fundraiser and income generator, so I've done everything from arrange colour runs and obstacle runs to running hospice charity shops. But now I work with a great team, and we have some great collaborations and partnerships across the blood cancer sector, work really closely with other charities, and it's really nice to be able to share that expertise and that kind of peer learning. And it's lovely to be at an event here in Belfast, because I'm myself just from Derry, although we are based in the UK and I live and work over there as well.
That's great. Thanks very much. I suppose when we were trying to kind of put this panel and create a discussion on what we were going to talk about, or put a plan on what we were going to talk about, one of the things kind of that kept coming up is the patients and active monitoring. And I'm kind of also aware that when patients are first diagnosed, the psychological impact, and we heard Paul's story this morning about how he was diagnosed, and it's kind of nearly in such a catastrophic way in the hospital, but most patients are diagnosed when they're actually feeling very, very well. And to be told that they have cancer and to go and come back in 6 months. And we know that, like from the graphs and the studies, that then patients' psychological impact and the stress levels and all goes all the way up, where when we look at patients that have other forms of cancer, I'm not taken away from that, but once they kind of when they get their treatment plan and they have a plan in place, the stress levels come down. So can you maybe talk about like what access maybe patients have to psychological, and and especially when you have well patients, and is there nurse-led clinics? And I suppose, Laura, I'll start with yourself.
I suppose when patients are first diagnosed with a CLL, it goes through something called a multidisciplinary team meeting, where we discuss your diagnosis, care, management, and there's usually a nurse specialist at that meeting who should then be reaching out saying, I'm available as support. Ideally, whenever you're first diagnosed, one of us should be there. There is not enough of us for that actually to be physically possible, unfortunately. It is the gold standard, but it is not remotely possible. And then you have people like poor Nikki, who is told online. So that is a whole other section. Before I was an AMP, I was a lymphoma nurse specialist, and whenever patients were diagnosed with a CLL, I would have sent a letter out saying, I hear you've been diagnosed with a new diagnosis. I'd make sure, obviously, they've had their appointment first. This is what is available. Here's all our contact details. Here's all supportive information details to make sure they're accessed and access is available. That was because I was one person in the whole of Belfast Trust, and now, thankfully, we have a few more. So the team is building slowly, not quick enough, but slowly, to be able to provide more support. Within that, we try and, as I say, signpost patients to different support. Not everyone will need the same thing. Not everyone will need full counselling. Not everyone will need, Citizens Advice Bureau. But we try and personalise that and direct people in the best way possible. I think what is extremely difficult is access to these services. A lot of them are all charity driven. So access to psychological support, a lot of it is paid through charities, and remember when I started, the waiting list for counselling was about 5 to 6 weeks, and now we're talking several months, and that has been massively hit by COVID. So I think it's trying to get more access to all these services as well. To try and streamline this a little bit better, we've kind of set up holistic needs services so that you can have a longer appointment. So as you know, when you go for your healthcare appointment, it's usually about 10 minutes long. That's very hard to put in everything that you want to talk about. If you have more to talk about, we try and get holistic needs assessment appointments. They're longer, about 45 minutes long, where we can talk through everything from financial, psychological, side effects, and then try and signpost out. And the nurse specialists usually run those as well.
That's great. And what I'm going to do is I'm going to stay away from the clinical speakers at the moment, and because it's kind of leading on to the patient advocates. And maybe if I bring Brian into this and what CLL support do to maybe fill that gap of when the psychological impact of a CLL diagnosis and what you do for patients.
Yeah, thank you, Michael. I remember back to the actual point of diagnosis. And you'll have experienced this, many of you here, and it is a shock. it's more than a shock. It takes your life at right angles to wherever it was you thought you were going. Because you suddenly realize, well, yeah, that's not going to happen like that anymore. Whatever your plans were, they've now changed. And it takes time to come to terms with that. We didn't find CLL support for a little while. And all of the information that we came up with was not encouraging at all. It was real relief when eventually someone said, well, there's this charity, CLL support, and it has developed enormously since that. I'm going back now, 12 years. It's developed enormously since then. And the level of support that you can now get from charities, including ourselves, of course, is enormous. I'd encourage everyone to do two key things, and just to reiterate what has been said this morning, because I thought that was really important. First is to learn as much as you can about CLL and you, because everybody reacts, every single person reacts differently to their CLL. Get to know the symptoms to look for. If you feel that you need to contact because the symptoms are getting worse, contact your medical team. Secondly, get to know your medical team. Get to know them really well. Your GP almost certainly has, my GP, our GP, had never had a CLL patient. And he'd been a GP for 32 years, and he hadn't had a single one in that time. So it took from us a little bit of education of what it was. So get to know your team, get to know who to call, have a phone number ready to call someone, because it could help you, and it could save your life. It's quite important that. CLL support, yeah, have a look if you need to our wellness website, which has a series of exercises which are designed basically to ease tension, to make you feel more content with yourself. And that's very, very easy to say, but it's blooming hard to do when you're worried about it. One of the key things is every 3 months or every 6 months, the stress levels start to go up, because you're going to have a blood test. And you don't know what blood test is going to be. You know, the first 3 or 4, fine, okay, you start to get used to it, but you never know what that result is going to be. And it is very difficult. So when the stress levels start to go up, a few weeks before, the week before, the day before, think about just logging on to the wellness website, on our website. Just go through a couple of the exercises, and it does bring your blood pressure down, I guarantee it, and it does bring the temperature down. So you give it a go. But whatever point in your journey, good luck to you.
And Ropinder, from a lymphoma action, and you know, we're kind of in a unique situation here. I don't know whether you people in the room know, but in the world, there's only 4 CLL-specific advocacy organisations, and you've got 2 of them in the room. The other one is CLL Society and CLL Canada. But also kind of the advantage, one of the advantages, if you can call it an advantage, is CLL is a leukemia and a lymphoma. And so we have Lymphoma Action that also advocate for patients. And would you like to let everyone know what you do and what you do for CLL specifically?
Yeah, sure. And on that point of active monitoring, I mean, I was really liking what you said about the fact that I like the word active monitoring as opposed to watch and wait, because it sounded very passive before, whereas active monitoring is you're actively looking for your symptoms and looking after yourself and seeing how you can be in the best shape possible as well for if you ever do have to start treatment. So I really like that active part of active monitoring. What we hear from people is that people really like talking to other people, like the peer support aspect as well. So, for example, we run online support meetings, which are sometimes topic specific, and we find that the active monitoring ones were so popular we had to put more of them on, because we weren't really sure when we first started them, you know, whether people would want to come to them. But people really do want to speak to other people, see how others manage active monitoring, what they interpret it as, and, you know, are they doing it right? You know, are they looking after themselves, and are they looking at their symptoms right? So we would recommend that kind of peer support. I think earlier on, bodies was mentioned as well, We do have a buddy service. We have actually got a prehabilitation service as well, which is online. When we did our research, sometimes there's a very short period between people being diagnosed with, for example, a lymphoma and starting treatment. So our prehabilitation service is online. But we have found that people who are on active monitoring and about to start treatment have also been wanting to access that service. So I think the key thing is everybody gets their support in different ways. Some people like listening to podcasts. Some people like to be on a closed Facebook group or on a forum or reading a booklet on active monitoring. So I would suggest, do what feels good for you, do what's best for you, how you like to learn, how you like to get your information. But I think information is the key, isn't it, to people feeling confident in going forward and having those conversations with their clinicians as well. There is a lot to discuss with clinicians. So I think, get your information from the charities as trusted sources, as opposed to, Google AI some researches or something like that.
Now, the clinicians don't get off the hook, and what I'm going to do is I'm going to move on to the questions that really are the telling questions for patients, or the ones that maybe keep patients up at night. And as the questions that we sometimes get asked as patients are on that pathway, but it's that mutational tests and genetic tests for patients. I remember going back the early years when I knew nothing about CLL, and Jan was in hospital one time, and I was leaving the hospital, and I met the doctor at the door, and he says, "Michael, I have good news. Jan is mutated." And I'm kind of thinking, I just left her in the ward. She seemed okay to me, and I didn't understand what it was. And I remember going on to Google, and I came across Terry Hamlin's. He had a blog, and it's still up for people to read, but it's called Mutations of Mortality. And reading that blog, he just put it into simple language, what mutations. So what I'm wondering, at that time, we kind of knew that if patients were unmutated, that treatment, if they had chemoimmunotherapy, they would probably relapse a bit quicker. And I know no two CLL patients are the same and journeys are different, but we're at a stage now where, kind of 10 years on of doing research, I actually don't know the answer to the question. And when a patient asks, when should that test be done, with whether they're mutated, unmutated, the chromosomal abnormalities? So Sarah, if you'd like to answer that question for us.
Yeah, no problem, Michael. So we touched on this a little bit during my session this morning. I think when someone is newly diagnosed, it's not necessary to always do those tests just at the time of diagnosis if the patient is under active monitoring. In my own personal practice, and it might be interesting to see what Ben does, I do tend to look at IgHV status, and we touched on this morning, and that's what you're referring to in that mutated versus unmutated. And I guess for patients who are unmutated, sometimes, and again, these are sort of speaking in terms of like averages or what you anticipate, but as you say, no two patients are the same. Sometimes patients who have unmutated disease, you might see a slightly more proliferative or type of disease, or one that may need treatment sooner rather than the mutated person. And in the time of chemoimmunotherapy, certainly patients who mutated tended to do better with that than those who were unmutated. I guess we reflected upon how the treatment pathway has evolved up to 2025 this morning, and we now are in an era of very targeted therapies. And I think the weight of that has fallen somewhat, but it is still clinically relevant. And I think for us as clinicians, and for you obviously as the patients, the one that still sort of changes our maybe initial steps might be when you need treatment will be whether you have that gene or mutation. I do tend to do it at the start when someone is diagnosed, and then I will certainly do it again before a patient needs to embark on treatment. But certainly the guidance that we work to is that it's not necessarily required at diagnosis, but certainly before you would embark upon treatment. I do find those tests informative as the person looking after you, but for some patients I know that they can carry that extra weight or worry, and so happy to explore that with the individual when we discuss whether or not the timings of when we do those tests. And I think again it should be individualised, and making sure that the patient is happy to be informed of those results and how we take those forward.
It's interesting, just before you pass on to Ben, that I know that Brian Kaufman, or not Brian Kaufman, your doctor, Dr Thornton, he wanted to run that test immediately, so it must be in Northern Ireland. He's from Belfast, so it must be a Northern Ireland thing. But we actually appreciated having the information at that time.
Yeah, and I suppose sometimes some of the discussions this afternoon might reflect variations in practice throughout the island, or between Ireland and the UK as well. I guess I work in a tertiary centre where it's easy to access some of those tests, so sometimes if you can do that, it's nice to know. But again, it's the sort of thing that I think it's important that we have a discussion together to make sure that, for example, if I have someone with a very mild lymphocytosis and everything else is fine and it's an incidental finding and I know we're embarking on active surveillance, do we really need to know at that point? So it's a discussion together to make sure that we're happy with what we're doing, that it informs us, but that also making sure it's the right thing and the right time to do that, I think.
That's great, thanks for that. And Ben, I'm going to kind of twist the question a little bit, that we saw all these different treatments, ibrutinib, acalabrutinib, zanubrutinib, you probably know where I'm going with this, venetoclax, obinutuzumab. How do you make a decision, when you do have these drugs available, how do you make a decision of what treatment is best for what patient?
Okay, so I think we're in a very different landscape from where we were when we were talking about chemoimmunotherapy. So that means combinations like chlorambucil, obinutuzumab, or FCR. These are now historical, right? We don't talk about those. I don't believe that anyone is ever suitable for those chemoimmunotherapies anymore when it comes to choosing. The good news is that the small molecule therapy, the targeted treatments that we speak of, are extremely good, extremely effective in almost every scenario, to be honest. So I think the choices are nuanced. Can we just row back a little bit? Is everyone in the room comfortable with what it means to be mutated or unmutated? Is that something that everyone knows everything about? What is mutated? What is unmutated? No? Do you want just a very quick thing on what that is? Okay, so when CLL starts off, the cell has got to develop into a malignant cell somehow. So it's got to undergo a series of mutations. Now, the CLL cells look under the microscope individually almost like normal lymph cells. You couldn't tell necessarily that it was a cancer cell just by looking at one cell under the microscope. So there are things that are happening inside the cell. And when B cells, these are cells that normally make our antibodies in the blood system, they're called B cells, and there's a group of cells called T cells, and the T cells are much cleverer. Okay, they're the ones that go and tell the B cells what to do, and they help coordinate the immune orchestra in a much more sophisticated way. Anyway, CLL comes from the B cells, and their role in life, if they were normal, would be go out and make antibodies. But to make antibodies, you have to have a fingerprint on the end of the antibody, something that's really specific to whatever bug or bit of a bug, viral or bacterial, that you're going to attack. It has to be a lock and key, very specific. So an antibody has to have something on the business end of it that is specific to the infection that it wants to deal with. And that's where the mutations come in. So it's very normal to have these tiny point mutations at the business end of an antibody, and you need those. So we call them, when you make good antibodies, they are mutated. So CLL, that has the ability, the machinery, if you will, to make those antibodies that theoretically at least might look more normal, those are what we call mutated immunoglobulin genes. So the immunoglobulin is antibody. So the genes have got these tiny little point mutations in them. And that's normal. That's what it should be. Now, if you've got the machinery, the genetic machinery to try and make those antibodies, and it doesn't have those mutations in it, then theoretically the only antibody it could make would be one that didn't have the fingerprint. It didn't have the key that would fit a lock. It's not as sophisticated, it's not as good. So those cells in some ways are less mature than the mutated cells. So we think of mutations as being bad, but you kind of have to flip this on its head. And it's a bit counterintuitive that these B cells are cells that either could make a mature antibody or they're unmutated and they wouldn't really have that machinery to do it, and they're slightly less mature cells. And CLL seems to split almost 50-50 into one or the other group. And for those people with these so-called mutated immunoglobulin genes, they're slightly more mature. It takes longer for those individuals, for the CLL, to build up and require treatment, on average. And on average, it takes a shorter period of time for the CLL to progress and require treatment if you have unmutated. So I hope that's helpful, but that's where it comes from. It comes from the antibody-making genetic machinery of the cell, and they're slightly different in the way that they grow and develop, in ways that we don't fully understand. And then there's this business of P53. P53, or 17p deletion, which affects the P53, is all about how does a cell respond to damage. And if you have an intact, the P53 protein is there and it's working, then if a cell gets damaged, it can switch this on and the cell will die off because it's got a process inside it that we all have, we all need it. It's part of being normal that if our cells are damaged, we can pull a lever and the cell will die off. And we need that. And cancer cells need that mechanism if you're going to use the blunderbuss approach of damaging them so the cell understands that it's been damaged and then does something about it. So with chemoimmunotherapy, you really, really need to have intact P53 for it to exert its effect and to kill the cells off. The really good news is that with the current treatments that we have, they work really independently of that P53 process. So it's not to say that those tests are not important. They are important, but the treatments that we have now circumvent the severely negative effects, particularly of P53 mutation or loss. So how do we choose? If somebody comes to me and they've got a 17p deletion, I've done this fluorescent in situ hybridization test, and you can see under a fluorescent microscope that they're missing a bit of their chromosome 17. Or you've done a next generation sequencing and you've looked at the gene and you can see a mutation in the P53. So how then do we choose our treatments? Well, if both therapies work, which one works a little bit better? We know, for example, that continuous BTK therapy with drugs that affect that B-cell receptor pathway probably have a longer, on average, effect. That if you start those treatments, the chances of the disease progressing is going to be probably, on average, 2 or 3 years longer maybe than if you had a fixed duration treatment, such as venetoclax with obinutuzumab. So for someone with a good-going P53 deletion mutation, I'd be thinking of the merits of a BTK inhibitor because I think that someone's more likely to have a longer duration of response. And there's nothing more depressing than disease coming back. You know, we know that. That's a thing. Disease coming back, psychologically, and all sorts of things, physiologically. You know, it's bad news potentially because it just throws a spanner in the works in all sorts of ways.